Hello, my name is Dr. Sarah Walker, and I'm honored to serve as the 2025 President of the El Paso County Medical Society. On behalf of our organization, I want to welcome you and thank you for tuning in to the El Paso Physician. For the past 28 years, the El Paso Physician has been dedicated to serving our community, and we are grateful for the continued opportunity to bring this program to you on PBS El Paso. This would not be possible without the generous support of our community sponsors who help us produce valuable content every month. If you or someone you know is interested in supporting this program, more information is available at 915-533-0940 or at epmedsoc@aol.com. Thank you again, and we hope you enjoy this program presented by the El Paso County Medical Society and hosted by Kathrin Berg.
Our children, you gotta love them. They have very different emergencies at very different ages. But when do you know when you have to go to the ER? When do you call 911? We're gonna talk about that specifically tonight. This program is underwritten by the El Paso Children's Hospital. And we also wanna thank the El Paso County Medical Society for bringing the show to you now for over 28 years. I'm Kathrin Berg, and this is the El Paso Physician.
Neither the El Paso County Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Thank you for joining us. Today we're talking about pediatric specialized emergency care. Why specialized? It's not just that somebody gets sick, they have to go to the ER. Kids get into all kinds of trouble, and it's summertime in their home. So we have a lot to speak about today. We are filming in the classic Turner home. I don't know if you've noticed that the last several times that you've been watching this program, but this is where the El Paso County Medical Society is housed. It is a Henry Trost building, and it's just fun to be here. So let's get to all of this. I would like to introduce Dr. Alfredo Maldonado. I did this last time too. You are the medical director of the El Paso Children's Pediatric ER. And then we have Miguel Arroyo, who is the attending physician of the El Paso Children's Hospital, also pediatric ER. Thank you so much for being here. And my big first question, El Paso Children's has its ER, obviously specialized for pediatrics, right? So I would like to let the audience know that you've got an ER. Do we just take them to an ER? But when is it that you have to go to a pediatric ER, and what is the specialized differences versus going to an ER that happens to also serve children? Does that make sense?
Sure, and thanks for having us today.
Sure.
So it's interesting, the majority of kids that are seen in emergency rooms in this nation are seen in general emergency medicine departments, or what it's commonly called an adult ER. And part of that is that there are very much less pediatric ERs around the country. And so just by virtue of there being many more general ERs, most of the kids get seen in general ERs. Pediatric ERs are specific because we are specifically designed to treat ill children, right? And that goes everywhere from having the physicians that are seeing them be pediatric emergency medicine trained, the nurses, the radiology techs, everything really is geared towards kids. And sometimes it might not seem like they're, an ER is an ER, right? And in many ways, and adult ER departments are trained to see kids from birth to death, right?
Right.
We focus in on a very narrow spectrum with our pediatric patients. And as such, with our training, it's all of our training is really dedicated to the emergency care of pediatric patients. So in terms of our training for the pediatric ER physician, we completed a residency in either pediatrics or emergency medicine. And then there's another 3-year fellowship dedicated solely to pediatric emergency room. Okay. Compared to a general ER physician who in their residency maybe does 2 or 3 months of pediatric training. And it's a lot of stuff, it's doing procedures over and over and over again on children. It's resuscitations on children. So even though both are trained to treat children with pediatric emergency room physician, that's the only thing that we care about and train for.
And I'd imagine your equipment too is very specialized, right? You don't just put little ones into a big old hunk of machine.
Exactly.
And I remember us talking a little bit about that last time. with budgeting and because there's always the administration of any hospital. And so specifically getting the equipment that you need for the littler ones, which is great.
Sure. And sometimes, like, a general emergency medicine department may not have the need for very small, ET tubes or things like that as often. And so supply, gets an expiration date and you end up wasting it, as opposed to the pediatric emergency room. We see those patients all the time and we use that much more frequently. It's easier to justify the cost for stocking everything that you need that's pediatric specific.
Mm-hmm. I like the way that you explained that. And I know that here on the border, we have every pocket of America has different needs, but we have specific issues here on the border. We have socioeconomic barriers. We have sometimes transportation barriers. In the time that you've been here, what have you seen is specific to our borderland when it comes to pediatrics?
Yeah, I think some of the barriers that I've seen being here, I think you kind of alluded to kind of transportation issues. Luckily in our ER, we have, taxi vouchers that we can provide families.
Great.
Because, El Paso is growing, it's becoming larger. And so, what used to take maybe like 10, 15 minutes from the east side to the hospital, now you're coming from East Lake, Horizon, from far west, Canantillo can take, at least half an hour.
Right.
And if the family doesn't have, a ride to come to us or any ER for that, for that matter, that can put a barrier to the families.
Absolutely.
The other thing probably just, we screen for a lot of, food insecurity up front, child abuse, kind of those issues that we screen for can sometimes pose a barrier as well. And you kind of alluded to socioeconomic factors. The good thing about the ER is that we see everyone regardless of whether they can pay or not.
Right.
So really, I'm not out there asking who has insurance, who doesn't. You come through my ER, I will treat you just like any other patient. So
exactly.
Although that might, some families might think, the ER bill is going to be really high. I don't think that should be, a barrier for the families.
And you all too are the point of contact for places outside of El Paso too. And that's, we're isolated, but we're not. We've got a lot of communities that are coming in. You've got Deming, you've got, people. And I do want to talk a little bit about the urgent cares that you have. I understand you're going to have two of them pretty soon. There's one, you're talking about East Lake area, and there's going to be one that's opening up on East Lake. It'll probably be open by the time this program airs, and then also one on Zaragoza. And either one of you, I'd like for you to differentiate what the urgent care, the pediatric specific urgent care is versus the pediatric hospital. Who wants to take that on, or you guys can kind of bounce back and forth?
Bounce back and forth.
Excellent, thank you.
So with, I think as a parent, it can be tough sometimes to know, who do I take my sick kid to?
Exactly.
Right?
That's the biggest question.
To the pediatrician? Do I need to go to the urgent care? Do I need to go to the emergency room? And because it's not necessarily common knowledge what should go where, and we certainly see patients that are probably more appropriate to one present to another. Right, and with the urgent cares, being able to take your child to pediatric specific urgent care, I think is extremely helpful, because there you'll get people that are also trained in seeing kids, and can be a little bit the same way that the adult ER is a little bit different from a pediatric ER. Same thing with urgent cares. When they're focused on pediatrics, they're going to be more comfortable dealing with kids and that. For when to go to the emergency room. In the emergency room, we certainly see a lot of patients that are not as sick to require emergency services, right? And they do, it does lead to very packed waiting rooms, because those patients, by virtue of not being as sick, a lot of times will sometimes have to wait a little bit longer, as the sicker patients obviously take priority in an emergency room. And so it's helpful to be able to filter out knowing where would be the more appropriate thing right from the start.
Right.
For an urgent care, I think the things that are probably a little bit more appropriate are things that you would probably go to your pediatrician for a sick visit, but either they're not open or you're not able to get visits, which happens obviously very often, especially during the busy seasons.
Okay.
So thinking things like, colds or a stomach virus, a sore throat. Some urgent cares have different capabilities, so at the El Paso Children's urgent cares, there's x-ray capabilities, so things like an injury onto an arm, things like
Great,
that.
because I was going to ask, somebody falls off the monkey bars at summertime. Exactly. Is that urgent care or is that hospital?
Yeah, and so anytime that I would say the ER, anytime there's an obvious deformity, we're in the
Okay.
summertime is when we see all of our injuries.
Right.
So anytime there's obvious deformities where you look at that and you're like, no, something's not right.
Yeah.
Like those, it's not even worth going there. That's straight to the ER, right?
Exactly.
It's making sure that you stop giving them anything to eat or drink because they may need sedation and they can't have anything in their tummy, and taking them to the ER because that's where the definitive care is.
Right.
We're fortunate at El Paso Children's Hospital where we're covered by orthopedics 24/7 in-house, meaning that 24 hours a day there's an orthopedic surgeon who helps us out in the ER with reduction of fractures that need to be moved or put in place. And so
It's true, because you ask any person, I think, I'm 58 years old, it's like, well, have you ever had a broken bone? Yeah, when I was 12, I did this. When I was 8, I did that. Usually rarely, unless you're in a sport, is there something that's like broken before that.
Sure.
And that will be one of my next questions too is, yes, it's summer, but let's first take overall, like what are the most common emergencies that you see in the pediatric ER? And then I'd also like to kind of go into summer because I do want to bring up heat stroke. I do want to bring up drowning. I do want to bring up just in general some of the protocols that you all have in place too. But what do you see the most?
Yeah, I think probably fever. I think fever is probably the most common thing we see. We see a lot of abdominal pain, trouble breathing, asthma exacerbations, especially with El Paso being so windy and dusty recently. I think those are probably my top 3 things that I've been seeing most recently.
So on those notes, specifically in your ER, because you know what the high acuity levels are, you have people, you have protocols. Talk a little bit about that to the audience so they can kind of get and see, boom, how people just can come in and help fix things immediately.
Yeah, I think so. The child and the family come in, and we have pediatric nurses that are doing the triaging. And right from triage, they have their specific protocol, whether it's, if they have a fever, how old are they? Can we give ibuprofen or can we give acetaminophen? They have asthma, how old are they and how much do they weigh? How much albuterol can we give? Things like, the nurse will recognize a really sick patient. Do they look like they're in, sepsis, septic shock, anything like that? Right away, they'll come grab us and they'll put the child in the resuscitation room. But we have specific pediatric triage guidelines that we use so that we can kind of tailor the child's care.
Okay, that makes sense. When you're looking also at, when you said sepsis, so I think that is a word that it's loaded. What is sepsis? How do you get to a point where a person has a little one, a child, and do we identify that anyone under 18? Do I remember that right?
I mean, it can be any age.
Pediatric. So how does one get to that point? Again, feel free to kind of bounce off of each other. So you start since you brought it up.
Yeah, I think so. Yeah, anyone can get sepsis from the newborn all the way to the elderly.
Right.
And it can recognize differently in the newborn versus like an 18-year-old that we see in the ER. We base it off of how does the child look? Does the child have a fever? How high is their heart rate? How fast or slow are they breathing? And what is their blood pressure? And really the main thing that causes sepsis would be, bacterial infections, but viruses can also cause sepsis.
And see, I feel like I never hear about viruses causing sepsis. I know about bacteria getting infected. Let's take both of those on.
I mean, it's not as common as like bacterial, but a child can have RSV or like a viral stomach bug, and that can cause sepsis, which can then lead to dehydration, which can cause a different type of like shock that we see in the ER.
Okay.
But yeah, bacterial is by far the most common thing and the one we want to avoid and what we can actively treat with antibiotics too.
Okay. And then when you're looking at this too, and maybe give me a case study of how long it would have taken for, once the treatment starts, for the sepsis to start subsiding to where it doesn't appear to be dangerous anymore. Is there a case that you can think of that was that situation?
So with sepsis, the sooner you can get antibiotics into the system, the better the outcomes, right?
Okay.
And you speak about a golden hour of having, getting antibiotics in within the first hour, but ideally, as soon as you can recognize it, the better. Patients that are septic basically have very severe infections, and it can very quickly lead to compromise of the organs and their organ function. So the heart, the lungs, right? And
it
so
goes fast, right?
It can go
and
fast.
That's the part that fascinates me.
And with kids, especially with younger kids, it's tough because they can look okay, and then they drop off the cliff. And it can be in the blink of an eye. And so part of recognizing sepsis early is appreciating that it does come with certain vital sign abnormalities, right? Certain physical exam findings. And those vary from age to age. And so, for example, at our hospital, we have sepsis screening protocols where every single patient that comes in gets screened.
Every
for
patient
sepsis.
that comes
every
in.
patient.
Okay.
And the majority of kids, they don't pass that screening, but it's basically trying to cast a wide umbrella to catch as many of these patients as possible, right?
Very nice, okay.
And depending on having a certain number of criteria, then that triggers the triage nurse to inform the pediatric attending, who will go assess the patient and be like, you know what, and we have it classified like red, yellow, green. Like how suspicious are we? Are they red? Is this definitely a sepsis? We need to hurry up and get stuff in within half an hour. Is it yellow? Where maybe it is, but you have a little bit more time before having to give antibiotics. Or is it green, where something else explains their abnormalities and unlikely to be sepsis?
Okay.
And a lot of that, it is dependent on the physician, right? And obviously, the more experience you have seeing very sick kids who are septic, the better you get at being able to identify these. And so, these are the kids that we see every day. And so, these protocols are put in place to really try and maximize not only identifying the number of kids who have sepsis, but also as quickly as possible to get them appropriate testing and treatment.
Well, I'm going to go to, I feel like this is something that's not new. It's been around a long time, measles, but it went away for a while, and now it's kind of coming back with a vengeance. I want to address it. So has it been, 5, 6, 7 months now where it really started to be, okay, we see a couple more cases here, and I have my measles shot, I have my little scar and everything, but why is that? Number one, why is the resurgence happening? And number two, what are we doing with it now? And where do we see that being a year from now? I know there's 3 questions in there, but again, resurgence, how and why, and how do we treat it right now?
I think the resurgence was, the most recent, because I think we've had, breakouts here and there over the last years, but I think the most recent was probably from, I think that area in West Texas where we had that one, measles case that then kind of started multiplying. And then measles is just so contagious that if you're unvaccinated, whether by choice or because you're too young maybe, or you have a compromised immune system, the patient can easily contract it. And I think that area, we're all in the whole West Texas area, and I think people travel, and I think it just made us way, with the families that have, parents that work in the oil fields out in that area, they come back home, they might not know that they, had, their little fever illness that they thought, could have been measles, and then they gave it to the child or the family.
And how serious can measles get? I think sometimes to those families, well, there's chicken pox, there's measles. I'm just thinking when we were a kid, we got all the shots for everything. Again, I'm 58, so just remember when we were getting all of our vaccinations. But how bad can measles get? Because it wouldn't be a big deal if people don't really get sick from them. Yeah,
measles can get bad. High fevers can cause dehydration, can lead to a pneumonia in the lungs, which can lead to the kiddo, not being able to breathe, ending up with, needing antibiotics because of a superimposed bacterial infection, ending up intubated, and can even lead to an encephalitis or a swelling of the brain down the line as well too.
Okay, so we're into June right now, 2025. How are we doing currently, and do you see this getting better within the next year?
I think this,
are we kind of at
Maldonado has probably more of the numbers, but I feel like it's gone a little,
I feel like
down.
I haven't heard as much in the last
The
several
Department
months.
of Health has a very nice measles dashboard on their website that you can kind of track to see the number of active cases, and you can follow the trend for the past few months. It does look, thankfully, like we're on the downswing of it. Like Dr. Arroyo said, it is super, super contagious. And it's interesting because really none of us that have trained recently have even seen measles in our lifetime, because we were so well vaccinated, and with herd immunity, it was something that really was seen in people that traveled abroad or primarily unvaccinated. And so when we started seeing cases in El Paso, our infectious control department, it was it was very kind of similar to when COVID started, where it was like alarms blared and all hands on deck, and we had to, everyone was on board with recognizing how contagious it is and how serious of a potential problem it was. And very quickly protocols were placed in terms of screeners with certain questions, trying to make sure, because even being in a room with somebody for 5 minutes, as far away as you and I, very easy to pass. So these were patients that we really needed to avoid them just sitting in the waiting room with other patients, potentially passing it on from person to person.
So this may be a bit controversial, but let's talk about vaccines for a second, because I know that kind of goes back and forth, and I think as the months go, we'll find, are these kids the ones that are not vaccinated, et cetera, et cetera. Because you are director as well, so you do get to do some of the administrative stuff. What are some of the things that you're hearing, both on a state, national level, and in general in healthcare when it comes to vaccines and certain vaccines?
Sure. So for measles specifically, the measles vaccine works very well. It's a 2-shot series. The first one you get around 12 months of age. That one protects you close to like 92, 93%. So
nice.
It works very well.
Okay.
The second one that you get a little later gets you up to like 97, 98%. So when you have a whole lot of people that are 97, 98%, it's very easy to protect those people who might fall in those 2%, or those people that are too young to receive the vaccines or immunocompromised, like Dr. Arroyo mentioned. And so it is a vaccine that works very well, but it only works well enough when there's enough people that have taken it.
You said herd immunity, so I thought, okay, let's talk about this.
Correct. Yeah. So the more people that you have that are vaccinated against a certain disease, the less likely they are to get it, and less likely to spread it to other people. Okay. With something as contagious as measles, it's very important to keep the herd immunity numbers high to be able to keep it from falling through the cracks and causing little outbreaks like this. Okay. And so once measles got here to El Paso, we worked very hard to make sure that we were screening digitally, right? And which meant sometimes screening people that, they don't look exactly the way the textbook says that measles looks, but because of how contagious it is, we need to make sure that it's not. So swabbing and testing people, putting them on the quarantine until we have some test results. And I think that went a long way to helping it be smaller of an outbreak than it could have been.
Okay.
And I don't have the exact number of how many we ended up seeing positive here in El Paso. I know the last positive case was probably about 8 to 10 days ago.
Okay.
Which is good, because initially we were seeing several cases a day.
Yeah, but you're saying 8 to 10 days ago. So that curve has really gone down, which is great. I want to talk about this before I get into some of the I have these rounds of, okay, let's talk about summer illnesses and things that are coming in. But I do want to talk about, because I think you guys do this so beautifully, is the mental health that El Paso Children's helps and puts around not just the kids, but the families, and how you involve everyone. Because I think that's something that we don't always think. It's like, okay, you came in and your ankle's broken and you got a knee sticking out, we got to fix all that. But there are other things too. And when we were talking about some of the borderland issues, sometimes we can only get one person to take to that child, and then everybody else is left at home, and or you've got all 10 family members coming. I'm asking the question of how you all handle the world of mental health at El Paso Children's. And again, this is something to kind of go back and forth. And it starts everything from someone who's got mental health issues, but also helping the families out when somebody's hurt.
Yeah, kind of also touching on the, protocols, whether you're coming into the emergency room for a mental health crisis or not, depending on how old the patient is, they get screened for certain questions that will then let us know, do they screen high for suicide or depression? Do they screen low? And if they screen high, what resources can we give them? So we have, starting from when you walk in the door, I think is, something great about, our ER.
So anybody that comes in?
Yeah.
I love that.
Anyone,
okay.
Obviously
okay.
they have to be old enough to answer the questions, right?
Yeah.
But the patients that come in, they get a screening. And if they screen a certain, they screen medium or high, they'll let us know, the physicians, and then after that we kind of huddle with the nurse that brings that up to our attention to determine what needs that specific patient has.
Okay.
But we've seen a lot of kids coming in specifically for mental health crisis, and we do approach it kind of like a whole family centered. We have our partners with Emergence Health Network that will come and interview not only the child, but also the parent. And then from there, they come up with some sort of treatment plan. What's the next step? Whether it's outpatient resources or whether it's going to an inpatient psychiatric facility. But I think we do a great job at identifying those patients and then providing the resources in conjunction with our partners at Emergence Health.
And that's spot on too, when you are able to partner with other people. And I love again, you were talking about the screening. So I love the protocols that are in place, screenings for almost everything. And I feel like people just know, in your department, okay, we're gonna look for this, we're gonna look for that, and then you kind of go from there. It sounds so simple, but it's not if it's not in place. You know what I mean? So I just love talking about this kind of being in place. All right, we were talking about protocols. I have no idea what WAPA is, but I'm curious. So working with pediatric specialists to develop protocols such as WAPA. So as we're talking about protocols, define what that is.
So with certain illnesses, there are protocols that have been shown to improve outcomes. So whether that's giving steroids quickly with an asthmatic, with a diabetic who comes in with GK, like certain things you want to follow. And these are evidence-based protocol, meaning that research has been done and proven that there are things that are helpful. And that we've developed several different protocols for different medical problems in our ER. And really all of them have been in conjunction with the subspecialists that relate to that particular problem. Okay. For example, the WAPA is our wheezing algorithm protocol, basically for asthmatics. And in conjunction with one of our pulmonologists in town, we came up with ways of trying to expedite identifying these patients right from triage by measuring what's called a CRS score, so basically like a respiratory score. And then depending on that, automatically having the triage nurse have a set of orders that they can start to implement rather than, especially if it's busy, having that patient have to wait to see a physician, to be evaluated, and then the orders get put in, right? So all these protocols are put into place to make things more efficient, and also it gives the nurses some autonomy in being able to start patients on certain protocols once they identify they're appropriate for those different protocols.
So, Dr. Arroyo, since you said that one of the big things, especially when we have our storms, asthma, we have an issue with that here. Prior to, and maybe there's just, I can't get a ride for another hour or 2 hours, we can't get to the hospital, we can't get to urgent care. Are there some things that you can, right now, for example, tell parents, okay, I know your child's have difficulty breathing, obviously get them out of the wind, the craziness out there, but what are some things that they can do on their own before they're able to get to you?
I think using their either their inhaler, their albuterol inhaler, or their nebulizing treatment as they were instructed to do by their physician or whoever prescribed that. Okay. That's one thing to do. And then I guess depending on how quickly they can get to the ER, if they really notice that their child is struggling to breathe, then the next step is calling an ambulance. Okay. I don't think parents should wait for that ride, 45 minutes to an hour, because those tiny little lungs are closing up quickly, and the quicker we can get some steroids in them and some albuterol in them, the better.
So I love that you said that, because I'm a fan of 911 calling to get somebody in there. I would love for you to describe physiologically, when you're talking about the little lungs, what is it that's closing, the little, I can see the pictures, but what is it that causes the difficulty in breathing? Like what is going on in the lungs? Yeah,
so we all have little muscles around our tiny airways and the base of our lungs, and kids that have asthma have kind of a hyperreactivity to those muscles, and so those little muscles will start to constrict the airways, little airways, which if you can imagine blowing into like a little straw, you get that kind of whistling sound. That's the wheezing that they hear, and so it makes makes it difficult for the child to breathe, because like I said, I don't think I could breathe through a straw. And so that hyperreactivity causes their lungs to start closing off, causing them to wheeze and causing them to feel bad really quick too.
So now when you're using a nebulizer, physiologically, again, if you don't mind, you've got albuterol going into the system, and what is that doing? Like I said, it's a steroid, so it's just trying to open everything up.
So the albuterol, a little different than the steroid that we give. The steroid we give is orally, and that's so that it can, while we're getting the albuterol in, the steroid is working in the body to help reduce kind of the inflammation of the lungs. As we're giving the albuterol works on those receptors in the lungs and those muscles to kind of relax and open their airways so that the child can breathe better.
Now that's a good way of visualizing it. Okay, I hadn't seen it in that way of looking at it before. Okay, summertime. Drownings. I want to talk about prevention. And we're not just talking about pools, we're talking about the backyard, we're talking about little people who tip themselves over. So Dr. Maldonado, I'm going to ask you to just give us some, again, maybe case studies. I like going to case studies because it gives people a story of, one time 4 years ago, a child came in with A, B, C, and D, this is how it could have been prevented, etc.
Yeah.
What do you see?
I think you're right. When people think of drownings, you think of being at the pool and somebody falls in the deep end. It's not noticed.
Right.
They don't make a whole lot of noise or splashing, and all of a sudden they're down at the bottom. But it's important to recognize we do see cases where even a few inches of water is enough for a toddler to fall in and drown from that. So even though the small little kiddie pools, it's like, okay, they're a little kiddie pool, they can just get up. There have been instances where toddlers or even infants have come in from drownings from those kind of things. So I think it's recognizing that it just needs to be enough water where if they have their face in it and they can't get it up, that can cause them to drown. So I think vigilance is a big part of it, and especially with our El Paso heat, everybody, getting in the pool feels wonderful, right? Kids love it. They can spend all day there, right? So part of it is vigilance in terms of things such as pool safety, making sure that there's fences around the pools, that doors that go out directly to a pool are locked. So that's kind of preventative stuff. For things like, say, a birthday party where it's going to be a pool party, designating somebody, hey, from this hour to this hour, you're going to be my lifeguard, right? You're going to be in charge, or you're not going to be, grilling or talking to your friends. Like, you're just going to be there watching all the kids, making sure that nothing happens, right? So even just somebody having that responsibility goes a long way towards preventing accidents that can happen.
I like that. I'm an old lifeguard. And to your point, and it doesn't have to be someone who's trained in lifeguarding. It literally can be someone who can pick the kid up out of the water. So I'm super happy that you said that, and I'll repeat that. If you have a party, just have one adult, even if it's a half an hour, you have a half an hour, you have a half an hour, but appoint them and look them straight in the eye and say, this is your job. This is your job.
I think one other thing that to add also that would be important is swim classes, because I think sometimes, especially in our community, our kids don't necessarily go to swim class. You learn by your older cousin throwing you in the pool and you kind of sink or swim and you make it that way. Right. But especially in the younger kids, I think swim classes can be super valuable, and they're offered at places like the YMCA. They even have some classes here in town where for even young toddlers, you teach them to turn onto their back and float on their back and kick, and things like that. I think are super helpful for those times where all the preventative stuff that we try to do to prevent these accidents, where they slip through those cracks and
if this is something that's interesting to you, there is an organization called the Drowning Prevention Coalition that provides the classes that you're talking about. You just take a little one, months old. And it sounds terrible. You blow them on their face and they learn to hold their breath and they just figure out how to flip to their back. And it's freaky to watch as a parent. I did it with one of my children. The other one was already too old. But you just kind of don't want to, but it's a life-saving event. Just if they can flip on their back, because they'll naturally float if they know how to flip on their back. So I love that you brought that up. I want to talk about allergic reaction. I feel like we talked a little bit about wheezing and something that could happen when you have an allergic reaction, but this can we can throw poisoning into that. We can talk about an allergic reaction from a scorpion biting someone, a bee stinging someone, just in general. When you don't know yet, because kids are so young, we don't know what they're allergic to yet. And so what are some of the things that you see in El Paso Children's Hospitals, people coming in with allergic reactions to what? And then how do you treat them immediately? And then how do you kind of coach the family from there on what that reaction is?
Yeah, so we do see allergic reactions. We see, hives presenting as allergic reactions, and then we also see, the anaphylaxis, which can be hives plus, you start wheezing, hives with, trouble breathing. If the kiddo starts off with hives and suddenly is coughing, or hives with swelling of, your face, your lips, your tongue, or the sensation of you can't swallow, you can't breathe. Yeah. Those are major anaphylactic symptoms that need to go to an emergency room as soon as possible. And we see it to various things. We can see it to bees, to ants, to food, to anything, essentially. And it's important for the family to kind of recognize that and immediately call 911 if, it's gonna take too long to get to the ER. Or immediately just come to the ER. Because 911 has the capability of giving epinephrine, which is the treatment of anaphylaxis.
Okay.
So the faster you get it in, the better.
And talk about, because I think it's nice because I feel like most teachers will teach other children if there's someone that has a severe nut allergy, for example. And it's like, okay, this is the EpiPen, this is where she keeps it in her backpack. I love that is a movement, at least it was in the school where my children were. Talk a little bit about that when a child is diagnosed to a point where they would be someone that carries an EpiPen with them.
Yeah, so
I just think it's good for awareness for anyone who's watching.
Yeah, we see them sometimes when, the very first big major anaphylactic reaction.
Oh my, okay.
And when I see those kids, I will print out, the anaphylaxis action plan, which the American Pediatrics has that, and I will fill out the medications that they need to do. And the good thing is with that sheet, it has what symptoms to look for. And then I'll prescribe them their epinephrine. And sometimes I'll even have the families go pick up the medicine before I discharge them, because what we typically do is we watch them for some time in the ER just to make sure the reaction doesn't come back. And when they bring back the epinephrine pens, they do, I think most of the time, come with teaching ones, the fake ones, so that we can show them.
Oh, I see. I get you.
And
okay.
even in, they don't have an actual needle, it's just kind of like a simulation one. Because if you've never used one before, I don't think
how would you know?
Yeah, how would you know?
Yeah, I remember, again, learning this as a parent.
Yeah, and then I think just last month or the month before, I called our pharmacy upstairs, and I was like, hey, can you guys come down and teach the family how to use it? And they were more than happy. The pharmacist came down, and using the family's, their fake EpiPen, they showed them how to use it. Okay. And so we had the family all squared away with, what medicines you need to give when you see X, Y, and Z. And they had their medications in hand, luckily for that family, because they went to go pick it up, so that they were able to have a safe discharge home.
Okay. Thank you all for doing that. I mean, the day is so different now than it was back, again, when I was young. We didn't have any of this type of stuff in school. It's summer. Yes, go ahead, please.
To add on to that.
Yes.
I think when people think of severe allergic reactions, the first thing we think of is the airway involvement. And I think one thing that as physicians we also do is anaphylaxis. It's a severe allergic reaction where it starts to affect the organs, right? And we also, as physicians, tend to think of the respiratory system, but we probably actually miss cases or delay diagnosing cases when it doesn't necessarily affect the respiratory system. So that involves things like the GI system. So severe belly pain with vomiting, that can be a sign of anaphylaxis, a severe allergic reaction. The sensations of the throat. So sometimes you might just hear the kid going, kind of clear their throat like they have something stuck in there. That can be a sign. Even just a subjective feeling like, I feel like it's tough for me to breathe, even if you're not hearing wheezing, even if they're not using their rib muscles to breathe, those can all be signs of a more severe allergic reaction. The last system to think about would be the neurologic system. So even being a little bit confused, passing out, being dizzy, those can all be signs and symptoms of a severe allergic reaction, to kind of just have in the back of your mind, knowing that it's not always just the lungs that are affected.
So we not joked about it, but at the beginning of the show, the hardest thing, again, as a parent or a grandparent, when is a child presenting enough to where I need to call 911? And you're describing some symptoms. We can also talk about, we had a cardiology show, and it's like, it's not, children also have heart attacks. They all, when are the symptoms bad enough for you to say, okay, I have to call 911? And I know it's an open-ended question, and I know it's a hard question to ask or answer, but you've got some that you think, okay, it's a hypochondriac mom, they're gonna go no matter what. And the other one's like, you'll be fine. I'm asking however you wanna answer that question. Fever, you were talking about a fever over a certain amount, so that could be one, correct? And then go from there.
Seizures, maybe, if you have the fever with the
Seizures,
seizure.
we haven't talked about seizures at all yet.
Yeah.
Okay, let's talk about seizures.
Yeah, with, febrile seizures are common in children, but if your child is having a seizure and has never had a seizure, I don't think as a parent, if I had never seen a seizure, I probably wouldn't know what to do.
So describe a seizure, because I know there's different descriptions as
so
well.
There's different types of seizures, but the most common thing that we see and that the public probably thinks of when they think of a seizure is your whole body kind of shaking. But there's other types where you can just be staring. One part of your body can just be twitching. It can even be like a subtle twitch. But there's a whole kind of like spectrum of seizures that we see. But the most common ones, specifically related to fevers, would be the ones where your whole body is shaking, or maybe part of your body is shaking, or you're just staring off, eyes rolling back, things like that.
Okay. Again, it's different with everyone. How long do seizures usually, or what is the window of normal seizures? And I can't even say normal seizures, but anywhere from 30 seconds to a couple of minutes. How is that usually?
Yeah, I think they can last, as long as a seizure wants to last, but we need to intervene within like 5 minutes,
Okay.
For us to give medicine, the 5 minute mark is the crucial point. So
5 minute mark.
Yeah, so they come into the ER.
Okay.
We stabilize their airway, their breathing, their circulation while we're obtaining some sort of access, whether it's IV, we drill a needle in their bone if we can't get an IV, or you can even give seizure medicines through the nose, your bottom, or even through the muscles too.
Okay, I'll tell you something. You just got my attention. We'll drill a needle through the bone. We're going to go to that in a second because I've never heard that before, but I'm super curious about it. So you said the first 5 minutes. Now we're going to a child at home having a seizure. They're not going to be able to get to the ER in 5 minutes. What can that? Obviously, call 911, get the ambulance on the way as soon as possible.
Yeah.
In the meantime,
they can turn them on their side, because
Okay.
they can start vomiting. Kind of lift their head up a little to open their airway, because if they're seizing and going like that, their little head is obstructing their airway, so they can't breathe. So those two things, and then I think also the parent, which kind of hard to do, but keeping as calm as possible too.
Sure. Yeah. Easy, like you said, easy to say. Okay, so you said if you can't get a vein, if you can't get an IV, you go into the bone. Is that a way to hydrate?
It is the way. Luckily,
I have not heard this before.
As emergency physicians,
Okay.
we're specifically trained to know how to place that in a child.
Okay.
So, if a child comes in for any reason that they would need emergent
course,
access,
right.
If we can't get an IV and they need something emergently, then the next step is to do an intraosseous needle, where we drill that needle, probably like this big in a child, into the first thing I tried was into their leg, to try to get medicines in there, because if you remember, inside the bone is the bone marrow, and that can absorb medications and fluids rather quickly. Yeah.
I love everything about hearing that. I did not know that was a thing.
And then we, as pediatric emergency medicine
Right.
physicians, we're specifically trained on doing that.
I remember my
kids.
daughter was 7 months old, and she diarrhea for days, would not eat, and they put an IV in her, and I'm like, how can you have something small enough to fit into a little worm? And I thought, okay, what if they couldn't find the vein? I was always wondering how that worked.
And
Sorry, my
in
voice
most
is hoarse.
instances, those children are, in what we call extremis, where
Right.
they're, probably not
But you're able to get
responding, but we're
medicine
able to
in
get
there.
it right away. Yes.
Yeah, fantastic.
And that's part of the beauty of the pediatric ER. In our ER, the nurses do the vast majority of our IVs, and so they're used to doing on tiny little babies up through adult-sized kids. In coordination with our PICU, we've had more and more of our nurses being trained at ultrasound-guided IVs, which is super helpful. There's some kids who are just tough, and you get those little chubby babies. Every time I see a chubby baby, I want to squeeze their cheeks, but then hope I never have to put an IV in them, because little chubby babies are super tough. And being able to, our nurses are getting trained more and more on doing ultrasound-guided IVs, which is super helpful in cases where there's
And just trying to
tough
keep the
access.
little ones still, like that in and of itself too, I can imagine
lot of
is
holders.
very difficult. I do want to I know we're starting to count down, but I want to talk about dehydration. I want to talk about just being in the sun, heat stroke, et cetera, et cetera. I don't know if it's stroke for a little one, but how important it is for parents to recognize, for example, being red-skinned but not wet, which means their sweat is not working. You know, what are the things there to look for as well? And I'm going to start with you and then go through you, because I know there's heat stroke, but there's also just heat exhaustion, but it all goes into one.
Yeah, I mean, living in El Paso, the desert, you know, I grew up here, so
Yeah,
I know how hot
right,
it is.
right.
But yes, some of the symptoms would be, you know, feeling nauseous and vomiting. Those are when you start kind of getting into like the exhaustion type. But the first one would be, you know, the child's really thirsty, like you said, red cheeks, not sweating, but then they start to, you know, feel really ill, dizzy, vomiting, and that's where going into the exhaustion, leading into like the heat stroke. But we want to catch them obviously before that, so recommending always keeping hydrated, especially if the kids are out during, you know, peak time, you know, 10 a.m. till,
right.
I mean, I think the weather says till 4 p.m., but I really think it's probably till 8 p.m.
Yeah, yeah.
But being out there at those times, constantly drinking water, and also not forgetting your hat and sunscreen too.
And that's something too, you were talking about assigning an adult to a swimming pool, but I feel like you should also do that with sun. I mean, just being hammered by the sun all day long, it's definitely going to take its toll on you. Poisoning, because I think that's another reason when people go straight to the ER, like something, I think under the cabinet, my child got into something, my toddler, et cetera, et cetera. Give me some stories about poisoning and what your suggestions are. I know that, you know, we child-proof the house, right? But there's still the Windex that you left out from cleaning the table the night before. Give us some stories of what you have heard and some ideas of what parents can do to try to prevent that.
So with poisonings, we tend to see two kind of peaks for when it happens. So you see in the toddler ages, right, when they're like little vacuum cleaners to get into every single cabinet. And then you see it later in the teenage years once they're doing it, trying to hurt themselves. Those are the two kind of peaks that we see people take medicines or substances they shouldn't. In the younger kind of peak with the toddlers, there are a few medicines where they're kind of classified as one pill can kill. I mean, even one pill of certain kinds of medicines, certain blood pressure medicines can cause devastating consequences.
Wow.
In the toddler, right? And so I think a wonderful resource that everybody should kind of have on their speed dial or on their fridge is the Poison Control Center. The Poison Control Center, it's nationwide. We have our own center right here, right next to the hospital, the West Texas Regional Center. And they are a wonderful, wonderful source of information. They're staffed by toxicologists who are specialists in poisonings, as well as other staff that's trained to deal with it. They have access to be able to look up to see, not only, okay, well, what medicine was it and what dose was it, and be able to tell you from home, because some things, even if you take 5 or 10, there's really nothing to do, and they can be safely observed at home. You can spare yourself a trip to the doctor or to the ER, but they can also let you know when it's something that's more urgent that you need to be seen, when it's something that, you know what, you need to call an ambulance and get seen like right away. So the Poison Control Center is super, super helpful.
And how nice to have your cell phone these days. You can literally pop that into the engine and get that phone number, right? Because I've called that number before. Scorpion bites. Oh, goodness.
Yeah, no, and then you're right. It's not just that poisonings in terms of stuff you swallow, but things like rattlesnake bites, scorpion bites. So they deal with all those kinds of toxicologic problems.
Okay.
Probably the cases that I've seen kids get most into danger with are when they get into like their grandparents' medicines, right? So their grandma's house, grandma had left her pills next to her bed.
Right.
They look like candy, and the kid takes a bunch of them, right? A is poison proofing, like you're saying. So really trying to make sure you enforce it whenever you're at somebody's house. Like, hey, can you keep these meds locked or up high where they can't get them, right? And in the case that a poisoning does happen, it's super helpful to be able to send them with a list of all the potential medicines that were at home, right?
Okay.
So these are all the lists that grandma's on. These are all the dosages. Counting those pills, being like, okay, I have 30 for the month, and I'm 10 days in, but I'm missing 15, right? That can be super helpful in terms of determining the potential exposure.
So if you're at home and you're a parent, this has happened. Again, it's going to take a little bit. Is there still, is it EPCCH? I can't remember do you ever induce vomiting anymore?
No,
I
it's
feel
really
like
not
years
recommended.
ago. Okay, and tell us why, because that again is old school and that's still in my head. Tell us why inducing vomiting is not.
Yeah. So I think a long time ago, things like EPCH, made yourself throw up, gagging yourself, going to the hospital and getting your stomach pumped is kind of what was.
I remember hearing that all the time.
Yeah. A lot of times they can actually cause more damage coming back up. You can aspirate, it can go into your airway instead. So it's not really recommended. It's important to recognize these things early. There's something called activated charcoal, which is just like what it sounds like. It's like liquid charcoal that helps deactivate a large amount of medicines so that they're less dangerous. That has to be given within the first hour after the ingestion. So time is of the essence.
Okay.
In cases where somebody either has a specific ingestion or a very large ingestion of a certain type of medicine, those do benefit from that.
So if parents are listening right now, they can find activated charcoal at a drugstore?
No, it has to be done in the ER.
It has to be done in the ER.
It's a matter of getting them to the ER very quickly.
Okay.
And poison control is helpful to tell you, hey, this is something that needs to get charcoal within the first hour. Get them there quickly. If you can't get there quickly, call an ambulance.
Okay.
And that's where poison control is helpful in helping guide.
Okay.
Once they get to the hospital, sometimes we have no idea what they took. Sometimes kids come in and they're just altered and acting confused. And, that's something that we're always thinking about in the back of our head is possibly got into something. And, there's blood work that we do, EKGs, different things that certain poisonings will present in certain ways. So there's, kind of what we call toxidromes, meaning that, you get certain vital sign abnormality or physical finding abnormalities that we're trained to recognize when thinking about poisonings that help guide us in terms of like our treatment and our testing and stuff that we have to do for that.
Wow, that's always so scary. I know we're running out of time a little bit, but I do want to talk about, and this is something that I've learned over the last several years about growth plates in children, because you said that there's an orthopedic person on 24/7 for broken bones, this and that and the other, and you're setting bones and you're doing surgeries, etc. Could you explain to the audience at home, breaking a wrist of a 4-year-old is very different of breaking a wrist of a 16-year-old because of the the fast growth that occurs in little ones and how those are set and difference. And I just think it's fascinating about the growth plate. And when I think 16 to 18 is about when your growth plate is going to be done?
So it kind of varies. So the growth plate is the part of the bone that is cartilage. So it's usually at the ends of it. And that cartilage turns to bone. And so as you grow, that cartilage turns to bone. That's how your bone grows. Once it's bone, that's it. It's solid. Girls' growth plates do close sooner than boys. So that's why girls tend to stop growing a little bit younger. The teenage years are usually when you kind of stop. Sometimes you'll get a kid who's like 19 or 20 and they still have a sudden growth spurt. So it can happen, but that's kind of more or less where when it usually happens. Injuries with fractures, you can have fractures through the growth plate, which is cartilage. They can involve the bone kind of above and below the cartilage, and those do have kind of different treatments, different outcomes. That's why it's important to have pediatric orthopedics, obviously very well versed with how to manage those injuries. A lot of times they're managed in very similar ways to older people who are grown. Like you said, when you're younger, your bones are much more malleable, and you'll get fractures that you can get about like this, but then when they heal completely straight. As you get older, you lose that malleability, and so you do have to be more precise in how they're lined up as kids get older and their bones are more skeletally mature. But it is amazing. Like I've seen, horrific fractures in little kids. You're like, oh my gosh, how's that gonna ever end up? But then it heals like nice and perfectly straight. Like it's amazing what the body can do.
The magic of our bodies. Okay, we have a whopping 5 minutes left. I want to stop asking my questions and ask you all if there's anything that you really wanted to talk about today before, when you're driving over here in the 108 heat. Is there anything that we haven't spoken about yet that you'd like to talk about, either one of you? I always think about what's coming in the future, which I love. And again, you all are going to have 2 urgent care areas. There's going to be El Paso Children's Urgent Care Facilities, one on Zaragoza, one at East Lake. That's where such of the population is. In general, what's going on that you want to talk about?
I mean, nothing specific, but I think in general, when a parent, if in doubt, just come to the ER.
Right.
I'd rather them come to the ER, nothing be wrong, than them wait and then something ends up being wrong. So I'd rather, parents are not doctors.
Right.
And even those parents that are doctors, I'm sure that, I'd be a
Yeah,
little...
you look at your own child differently.
Yeah, exactly.
Yeah, you really do.
Exactly.
You'll notice something wrong in someone else, but not in
Yeah,
your own
yeah.
kid, because you're there all the time. Dr. Maldonado, how about you?
I would say that if I think about the years that I've been here and in practice, the sickest kids that I've seen are those that have chronic medical problems who get a cold, get a pneumonia, get something else on top of it. I think the beauty and what, growing up here, like I remember what it was like before we had a children's hospital, right? And one of the best things that's happened as a result of the children's hospital opening is that we have so many more specialists here that we used to. Mm-hmm. And the wonderful thing is at a true children's hospital, like El Paso Children's Hospital, we have all these specialists at our fingertips. And they send their patients to us when their patients get sick. We are very well versed with dealing with patients with multiple medical problems who get very sick. So, mm-hmm. I think that is one of the benefits of having the ER, which hopefully you don't ever have to, utilize, but we're there when you do need to.
Yeah.
Another thing that's going to be coming soon that is going to be wonderful that we're looking forward to very much in the ER is we are looking to have our ER expanded. Mm-hmm. Currently, we have a 10-bed unit with like a 3-bed kind of area with a kind of like a fast track area, or we call it a rapid assessment zone. But we're slated to actually expand by the actual number of beds are kind of still up in limbo, but mm-hmm. anywhere from like 7 to 9 beds, which is going to be huge. It's because half the battle of being able to see all the patients that come in is we just don't have space. Yeah. And the patients are wonderful in terms of sometimes we have to see patients in hallways, sometimes we're behind little curtains, which is never ideal. Right. But it's the only way we can get to the patients that are in the emergency room, and having these extra beds is really going to be wonderful. It's going to include full-size resuscitation bays for when we have these critical patients. It's going to include dedicated areas for those lower acuity patients so that we can kind of get through them faster, dedicating things like nurse practitioners that we have working with us in the ER who are invaluable, and they're really wonderful at seeing these lower acuity patients much faster than the physicians are, because a lot of times we're tied up with the sicker patients. Yeah. And having dedicated areas to that for them to be able to be seen, I think is going to be huge.
I love that about our region, is that there are more and more places to be able to go now, which again, over the last several decades has been phenomenal to do. Dr. Miguel Arroyo, thank you very much for joining us. Dr. Alfredo, which I didn't say earlier, Maldonado, thank you so much. Again, medical director, attending physician. And if you are just now tuning into this program, or if you want to watch this program again, or if you want to have it running in the children's ER, there's 3 different places you can do that. So you can go to pbselpaso.org, find the El Paso Physician on there. You can also go to the El Paso County Medical Society website, and that is epcms.com. And a lot of people are able to find these programs with YouTube. So just in YouTube, type in the El Paso Physician, you can type in El Paso Children's Hospital, you can type in Pediatrics, and throughout the months and the years, you will also see different topics there that you might be able to come back and watch as well. Thank you so much for being here. Again, this has been Pediatric Specialized Emergency Care, specifically here in the Borderland region. I can't thank you guys enough for taking care of our babies, and then hopefully I'll have grandbabies eventually someday. But I'm Kathrin Berg, and this has been the El Paso Physician.
The El Paso County Medical Society is a nonprofit organization established in 1898 that unites physicians to elevate the health of the El Paso community. We have been bringing the El Paso Physician television program to your home for the last 27 years on PBS El Paso. If you should have any medical questions relating to this program, you may email us at epmedsoc@aol.com, and we will try to have our experts answer your questions.